I'm Tal Geva, Chair of the Department of Cardiology at Boston Children's Hospital and the Alexander S. Nadas Professor of Pediatrics at Harvard Medical School. I'm also Chair of the American Heart Association Writing Committee that developed this scientific statement titled Long-Term Management of Right Ventricular Outflow Tract Obstruction in Repaired Tetralogy of Fallot.
My name is Rachel Wald. I'm the Vice Chair of the Scientific Statement. I'm a pediatric and adult congenital cardiologist in Toronto. I'm a professor at the University of Toronto, and I'm also the Research Director of the Toronto ACHG program.
We want to take this opportunity to thank the American Heart Association and its councils on lifelong congenital heart disease and heart health in the young, and the Council of Cardiovascular Surgery and Anesthesia for commissioning this scientific statement. And in addition to Rachel and me, we have a wonderful writing group.
So we're going to start off by answering the question why this is a very important scientific statement to have published.
Thank you, Rachel. Right ventricular outflow tract obstruction manifesting as stenosis, regurgitation, or both is nearly universal in patients with repaired tetralogy of Fallot. And it precipitates a complex pathophysiologic cascade that leads to increasing rates of morbidity and mortality with advancing age. As the number of adolescent and adult patients with repaired tetralogy of Fallot grows exponentially due to excellent survival during infancy, the need to improve late outcomes has become an urgent priority. This AHA scientific statement provides an update on the current state of knowledge of the pathophysiology, methods of surveillance, risk stratification, and the latest available therapies, including transcatheter and surgical pulmonary valve replacement, strategies for management of lifelong and life-threatening arrhythmias, and it reviews emerging evidence regarding the roles of comorbidities and patient-reported outcome and the impact on the quality of life in patients with repaired tetralogy of Fallot. Additionally, the statement explores available evidence regarding clinical choices such as transcatheter and surgical PVRs, discusses criteria and options for intervention for failing implanted bioprosthetic valves, and considers a new approach to determining indications and optimal timing for this procedure.
Tetralogy of Fallot is the fifth most common congenital heart disease lesion, occurring in 34 per 100,000 live births, and is the most frequent cyanotic congenital heart lesion. The etiology of tetralogy of Fallot is multifactorial, incorporating genetic and non-genetic factors. Up to 1 in 4 patients have an identifiable chromosomal abnormality, which is thought to directly impact on clinical outcomes.
The pathophysiology of repaired tetralogy of Fallot is a complex process, and as you can see in the diagram, the reconstruction of the RVOT to relieve obstruction is integral to the primary surgical repair in this condition. It usually involves disruption of the pulmonary valve integrity, which then leads to pulmonary regurgitation in the majority of patients. Even when a valve-sparing approach is attempted, the majority of patients encounter varying degrees of RVOT dysfunction, including regurgitation, stenosis, or both. In addition, some patients may have residual or associated anomalies such as tricuspid regurgitation, residual ventricular septal defect, or branch pulmonary artery stenosis. All of these abnormal anatomic and physiologic findings then lead to a complex, slowly progressive pathophysiologic cascade that can ultimately result in a mechanical electrical cardiomyopathy of repaired tetralogy of Fallot.
There are various pathophysiologies and considerations when thinking about sequelae after primary surgical repair of tetralogy of Fallot. Broadly, these include PR, pulmonary regurgitation, which contributes to RV dilation, eccentric hypertrophy, diffuse fibrosis, It may ultimately result in an adverse impact on systolic function of both the RV and the LV. PS, pulmonary stenosis, results in RVH, diffuse fibrosis, and diastolic dysfunction. There's a mixed picture of dysfunction combining both PS and PR. There are also additional lesions to consider, the most commonly of which is significant tricuspid regurgitation, but can also include branch pulmonary artery stenosis, residual shunts, among other types of anatomies. Finally, there are various demographic and clinical factors which have been identified as risk factors. These include older age of primary repair, having a previous palliative shunt, obesity, and various genetic factors.
An important part of caring for patients with repaired tetralogy of Fallot is to identify risk factors for adverse clinical outcomes. And the rising rates of premature death, life-threatening arrhythmias, heart failure symptoms, and exercise intolerance in this rapidly growing population have prompted numerous investigations aimed at identifying those at high risk for morbidity and mortality. Identifying risk factors for adverse clinical outcomes and developing and then validating risk factors algorithms are essential for data-driven clinical decision-making for timing of interventions such as PVR, ablation, defibrillator, or heart transplant.
So next I'll take you through the highlights from 3 studies on risk stratification. The first comes from the Brompton, published in 2022 by Goniam et al. And it's a risk scoring system that they propose as a combination of clinical factors and imaging factors, including age greater than 50 years, sustained atrial arrhythmia, BNP level, aerobic capacity, ejection fraction, and late gadolinium enhancement. These factors can be combined to propose a risk score which can predict mortality. The second risk stratification approach comes from the indicator co-investigators published earlier this year by Mayurian et al. In this paper, there's a combination of clinical features, including age, obesity, type of surgical repair, and imaging features, specifically RV and systolic volume index, and a biventricular global functional index, which can be combined to predict mortality. And finally, there's a paper from the Correlate Registry published by Kovacs et al., which looks at factors associated with the superior clinical status based on patient-reported outcomes. This is a combination of demographic, clinical, and imaging features, specifically asymptomatic status, absence of a syndrome, having gainful employment, white ethnicity, and or better systolic LV function.
Next, we would like to take you through indications for pulmonary valve replacement in patients with repaired tetralogy of Fallot. The overall construct of this framework is to first recognize whether patients have symptoms or they are free of symptoms. Those who have symptoms would require at least 2 criteria, and those who are symptomatic require at least 1 criteria. And there's 5 of them. So those who have at least one of those criteria and have cardiac-related symptoms would then be considered for pulmonary valve replacement. Those who are free of symptoms and have at least 2 of these criteria then would be considered for pulmonary valve replacement. Those who do not fulfill these criteria would then be further considered for pulmonary valve replacement based on presence or absence of hemodynamically significant residual lesions. For example, a shunt lesion with a pulmonary to systemic flow ratio of 1.3 or higher, or aortic regurgitation that is moderate or higher, or if they have sustained ventricular tachycardia. So that is a relatively new and forward-looking set of criteria for considering pulmonary valve replacement in patients with repaired tetralogy of Fallot.
So now we'll hear from Dr. Carlos Mary on the topic of surgical PVR. Dr. Mary, Can you please describe the state-of-the-art indications for and results of surgical PVR? And what is your perspective on the choice between surgical and transcatheter PVR currently and in the foreseeable future?
Thank you so much for the question. In terms of surgical valve replacements, there are multiple different types of surgical valve replacements that we use. But in general, I think they can be categorized into stented bioprostheses, either bovine pericardial prostheses or mounted porcine valves. And these are the most common valves that are used because of their durability, availability, no need for anticoagulation, and just the ability to provide a landing zone for transcatheter valves. The other big category is going to be your biological conduits, and that includes homographs, both aortic and pulmonary, bovine jugular veins conduits, and bioprosthetic conduits that include either a bovine pericardial valve or a porcine valve. The results of these different types of surgical valve replacements are good overall. Most users report a perioperative mortality of between 1% and 2%. And there's some degree of pulmonary valve deterioration with time. It tends to occur about 10 to 15 years. So our freedom from reintervention of these valves will be basically about 95% at 5 years, between 83 and 95% at 10 years. And then you get a hit, and so between 50 and 85% at 15 years. In terms for indications for pulmonary valve replacement, I think those have evolved. Before, we used to have very simple guidelines based on right ventricular diastolic volumes. But I think we now have recognized that there are many factors that should play into when is a good time to replace a pulmonary valve, either surgically or transcatheter. And that includes different factors like age, obesity, the type of anatomy, right ventricular function, left ventricular function, and yes, some of the systolic and diastolic volumes. I think in terms of how to choose between a surgical and a transcatheter valve, I don't think that comparing them both is necessarily the best way to go about this. I think they're both complementary to each other. So I think the best approach is to look at the patient's journey in a big picture way, and then come up with a thoughtful strategy of when do we use surgical, when do we use transcatheter, and how do we combine this? So it's almost like a chessboard, and we want to get to a particular point. So what is the strategy for this particular patient that's going to make sense? And that will include a combination of surgical and transcatheter valves throughout the entire approach. So just a coordinated approach between surgeons, interventionalists, and cardiologists is the way to go. Now, in terms of a particular aspect, there's going to be considerations in terms of patient, provider, technology, anatomy of the right ventricular outflow tract, whether the patient needs other interventions that need to be done surgically or not, what are the number of sternotomies, what is the risk for that particular patient in terms of surgical risk, whether it's endocarditis or not, whether the valve needs to come out. And I think all of these factors in a multidisciplinary fashion are what should allow us to decide whether for that particular instance, the patient should have a surgical or a transcatheter valve.
Dr. Mary.
Next, we'll hear from Dr. Dov McElhaney about transcatheter pulmonary valve. Dr. McElhaney, can you please describe the current indications and results of transcatheter pulmonary valve replacement, and what is your perspective on the choice between surgical and transcatheter pulmonary valve?
Thanks, Tal. Yeah, it's an interesting question. The current state-of-the-art indications for transcatheter pulmonary valve replacement, it's really always in motion because there's new technology and a sort of growing understanding of the outcomes of these procedures all the time. So we're constantly learning more. But I think it's generally sort of accepted, in 2024, that transcatheter pulmonary valve replacement is a suitable option for surgical replacement in most circumstances. Occasionally, there's an indication for surgery that can't be addressed as a catheter procedure, or there are other circumstances that make patients either not a good surgical candidate or not as good a transcatheter valve candidate that might favor one or the other. But I think it's, I think, becoming more and more accepted that a catheter valve is pretty much comparable to a surgical valve, and that patient considerations, preferences, for whatever reason, sort of factor high in the decision-making process. Results, again, many of these procedures, we're looking at very long-term results as sort of the critical results, and that just takes time. So for some of the transcatheter valves, we now have outcomes out certainly beyond 10 years, approaching 15 years. We're learning more and more about longer-term outcomes, and what we're learning is, for the most part, favorable in terms of transcatheter valve durability. There's some valves that are younger, and we don't have nearly that much outcome data, but as time passes, we learn more and more. I think we have better means to compare catheter and surgical options. But I think at the present time, in most circumstances, outcomes are fairly similar between catheter and surgical valve replacement if you're trying to look at comparable patient populations, age groups, and so forth. In terms of the choice between surgical and transcatheter valve therapy, it's really a consideration that should be made in terms of lifetime management. It's not necessarily just what's best for this patient today, but also what's going to be best for this patient in the course of their next 30 or 40 or 50 or however many years of life, and whether a catheter valve sets them up better for the future, or a surgical valve now followed by a catheter valve in the future might be a more appropriate option. I think we generally consider that patients are going to need multiple additional valves in the course of their lifetime. So what we do today is not relevant just for their current status, but also for future options. So it's really an area where I think there has to be this paradigm of collaboration between cardiologists, interventional cardiologists, and surgeons to try to help determine what the best option is, period. From my perspective, though, there aren't a lot of downsides to catheter valve replacement relative to surgical valve replacement in general. In specific circumstances, there may be, but in general, catheter valves do what they're supposed to do. They provide a competent valve without obstruction. They allow the right ventricle to remodel, and they help patients become less symptomatic, improve their functional status, their quality of life in a manner that seems to be comparable to surgical valves. So from a pure sort of acute and short-term efficacy point of view, I would think that it's certainly favorable to get a catheter valve if that's what the patient wants. If there are other considerations, other factors that they're bringing to the table, that's certainly understandable. But it's a pretty good time right now in terms of available technology and options, and that's only going to continue to progress as some of the newer valves go into longer-term follow-up and we learn more and more. Thank you.
Thank you, Dov.
And now we'll hear from Dr. Jeremy Moore about arrhythmias. Dr. Moore, what is the mechanism of atrial and ventricular tachyarrhythmias? What is the recommended therapy for atrial flutter and atrial fibrillation? What is the recommended approach to managing ventricular tachycardia?
So the two main mechanisms for atrial and ventricular arrhythmia in patients with repaired tetralogy of Fallot are reentrant and focal. Reentrant arrhythmias are characterized by repetitive electrical activation through a generally well-defined circuit pathway. There's usually a critical element in the pathway that is most susceptible to treatment, whether medication or catheter-based approach. A second and much less common mechanism is focal tachycardia, where a small region of myocardium is responsible for the arrhythmia. These tachycardias are characterized by centrifugal spread of activation from a point source to the rest of the atrium or ventricle, depending on which chamber is involved. For atrial flutter, treatments consist of either pharmacologic therapy or catheter ablation. In general, pharmacologic therapy can be challenging to implement since many of the drugs can result in serious side effects that include proarrhythmia in a small number of patients, or even end organ toxicities in the case of amiodarone. On the other hand, catheter ablation is well established as a more definitive therapy for atrial flutter and congenital heart disease. This involves a three-dimensional mapping procedure of the electrical circuit and a focused elimination of the critical elements that support the tachycardia. Similarly, atrial fibrillation is, we're seeing it more and more in the aging adult tetralogy of Fallot population, and this can also be treated with antiarrhythmic drugs or catheter ablation. Catheter ablation is becoming more regularly utilized as we are gaining experience with this in congenital heart disease in general. For ventricular tachycardia and repaired tetralogy of Fallot, this has historically been treated by defibrillator placement. If it's in response to a previous episode of ventricular tachycardia, we refer to this as secondary prevention. Essentially, we're reacting to the arrhythmia after it's already occurred. On the other hand, for patients without prior ventricular tachycardia, but that we deem high risk for future events, primary prevention defibrillator placement can be pursued. Defibrillators in tetralogy of Fallot are highly effective, and they can prevent future sudden cardiac death events. Unfortunately, it's known that defibrillators can also cause inappropriate shocks, they can become infected, and they may need to be extracted with high-risk procedures, all of which can lead to lower quality of life and patient morbidity. So based on some seminal work in the mid-2000s, catheter ablation is an increasingly utilized manner or strategy for eliminating ventricular tachycardia and tetralogy of Fallot. So for selected patients with tetralogy of Fallot and monomorphic VT, this may be even considered a curative approach, bypassing the need for defibrillator placement. The main issue as it concerns the electrophysiologist for transcatheter pulmonary valves is the inability to successfully ablate these ventricular tachycardia circuits after the valve's been placed. For the newer self-expanding valves associated with large proximal skirts that can cover significant portions of the right ventricular outflow tract, we are worried about this as the VTs originate at these exact locations. Although we follow the morphology of the right ventricle, the size of the right ventricle, the health of the right ventricle carefully as we plan the timing of these transcatheter valves, the ventricular tachycardia substrates are also developing insidiously in the background, and we don't have really good ways of monitoring or detecting these ventricular tachycardia substrates. So the period before the transcatheter valve goes in is really the ideal time to assess for these VT, ventricular tachycardia substrates, by EP study, and also address them by catheter ablation when they're present.
So Rachel, what do you think readers of our paper should take away as the most important clinically applicable message?
I think the identification of risk factors, risk stratification to pick out patients who can have earlier interventions, and hopefully we can modify longer-term outcomes, lessen morbidity, lessen mortality. We have a lot of clinical tools now, the expansion of imaging, clinical factors, demographic factors, genetic factors. I think this is all going to be combined in the next few years and will translate into longer lives and better lives for our patients. Tal, what do you think is the most exciting piece of information that we can take away from the statement?
Thank you, Rachel. For me, the most exciting part is the development of a new framework for indications for pulmonary valve replacement, the shifting away from purely volume-based to a more comprehensive set of criteria that are based on the most recent set of data that has been published in the last couple of years.
Some of these unanswered questions which pertain to outcome include the following. How can we improve outcomes and prevent harmful consequences of the deleterious pathophysiology in this population? Potential areas of research focus can include a deeper understanding of the implications of, along with the early detection of, subclinical myocardial disease, methods of identifying or anticipating pathophysiologic transformation from reversible to irreversible cardiomyopathy, development of less invasive and more durable, safe, and effective therapies to eliminate or mitigate the consequences of RVOT dysfunction, and methods of promoting complete right heart recovery from the accumulated insult of chronic RVOT dysfunction.
In particular, additional research is sorely needed to better understand the ideal timing of pulmonary valve replacement, including whether there are accessible clinical metrics, imaging and electric biomarkers, or AI-based tools that further inform indications and timing of PVR, whether there are medical therapies that can ameliorate or mitigate the adverse impacts of pulmonary regurgitation or RVOT obstruction, whether it is possible to provide better protection at the time of initial repair against anatomic, electrical, and hemodynamic sequelae of the surgical repair, leading to RV and LV deterioration over time, development of long-lasting PVR options, for example, allogenic valve transplantation and improved transcatheter options, as well as research into risk factors and outcomes of endocarditis complications after transcatheter or surgical PVR, to establish new prospective multicenter registries to gain new insights about the evolving natural history and pathophysiology of repair tetralogy of Fallot, and to inform future interventional trials, and finally, explore the potential impact of genetic anomalies on risk stratification and the potential for patient-specific therapies.
Tal and I would like to sincerely thank the writing committee for their ongoing support. We hope that you read our paper and that you find it helpful in your practice. And finally, on behalf of the entire writing committee, thank you for taking the time to watch our video.